just want to remind everybody where you can mute or unmute, where you can have your video on or off, and we will be having it on for most of our session today. So you can see view participants down here or up above. There's a chat box for questions, and if you have any technical difficulties, please do use the chat box to let Leah know, and she will try and help you out. I also just want to let you know that we'll be moving around a bit into Zoom rooms, which most of you are probably familiar with. So before we move on, I just want to make sure that the chat box is working for you. Please show us the chat box is working for you by just typing the question that is at the front of your mind in terms of what community health centers could look like in our region. So you've heard about this, we've been talking about it. What's your top question? Just go ahead and chat and type that, please. So just again, the purpose of this webinar is to present, clarify, and improve the draft vision. It's really an opportunity to ask questions and comment directly on specific components. So this is a bit more of a workshop than it is a webinar per se. We will be moving, we will be having a short presentation by Dr. Smart about sort of what this vision looks like. And then we'll be asking you to generate clarifying questions working in small groups. Then we'll come back and we'll have a chance for you to direct those questions to a panel comprised of Dr. Smart, Laurie Varigan, and Jan Morton and Andrew Earnshaw, who are sort of our panel for today. And then we'll move into small groups again to really make sure you have a chance to share your feedback on what you like, what you don't like, what are kind of outstanding concerns for you, to share that feedback. Okay, and with that, I would like to hand over to Dr. Smart, who's going to help us understand a little bit about the background to this initiative and how we got to this vision and the vision itself. Dr. Smart, the floor is yours, and I will change the slides and hopefully get them in the right order. Dr. Smart, we need you to unmute yourself there. I know we all struggle.
No, it was so much better when I was muted, really. It was just incredible, but now you've done it. So hi, everyone, and thanks for coming. So just a bit of background. Again, the Kootenay Boundaries Divisions has been facilitating an engagement process to look at what the appetite is and what the potential is for developing a network of community health care centers, clinics in our area. So last spring, we started this with a series of just discussions about the future of clinics. And this was amongst practitioners. We had those discussions in the spring, and we heard that there was an interest in people taking this idea further. So in June and July, we had a series of webinars and to learn from other practitioners and administrators who are already involved in CHCs. So based on that learning, we developed a vision for what the Kootenay Boundary Community Health Center Network might look like. So at the same time, private clinics in Roslyn Trail and Castlegar have been considering merging for a number of different reasons, or in the case of Trail, actively working towards a merger. So as we thought about how to move ahead, it seemed to make sense for Kootenay Boundaries to sort of incubate it. It seemed a bit of a daunting process, especially for people who are already working full-time. And to incubate it means to provide some sort of governance or help with startup funding and to set up systems and structures that would be needed to support a network of CHCs in our area. So most recently, we have been developing a plan of how we might support a startup of the CHC network. So, and I think, are we there? So we're going to reflect a little bit on where we are now. We know that the traditional private practice model seems increasingly difficult or even unsustainable. The administration aspects of running a private clinic are a burden for many physicians, and the private practice model is less and less attractive, especially to the new grads. As a result, we have a serious recruitment challenges in the face of losing some of our older docs to retirement. While some of the clinics are currently doing great, others have been unstable, and still others even in crisis. Sorry, my profile just decided that it needed to jump in. So from a patient perspective, this translates into being unable to get a doc and long wait times for appointments. So the estimate is about 15,000 patients in our area are unattached. The difficulty see a doctor could prompt patients to look for options like Babylon or TELUS Health or any other corporate online virtual services. And there's a bit of a worrying surge of corporate healthcare. So in Richmond, BC, it's hard to believe, but a third of clinics are corporately owned and operated with no physician governance. We also know that the traditional private practice model is not always well equipped to connect with the community services in order to address things like social determinants of health. So all of this undermines just our best efforts at community continuity of care. Are we on, there we are. So in BC and other parts of Canada and North America, the community healthcare centers have been proving to be effective and efficient way to deliver care. So patient attachment, and I really want to note, we noticed physician satisfaction is much improved in these multidisciplinary team-based care venues. So patients have an easier time accessing appointments with MDs or other team members through online booking and extended hours. The appointments can be phone call, virtual appointments, or clinic appointments, just as we are using currently. The greater stability in the team approach of the community healthcare centers is generally very attractive to new docs, making recruitment quite a bit easier and is helpful in retention. And actually, we've seen that in Kamloops, in the Kamloops model, where even though they are so underserved, docs very much wanting to join the one group that is doing this. Doctors are able to focus on practicing medicine without the burden of being responsible for managing real estate or administration. And the CHC model builds on the primary care network, where all the providers are working to their full scope of practice and delivering integrated care. So patients are able to see the right provider at the right time for the right issue. So when primary care is integrated with the complementary private and community social supports, the healthcare providers are able to remove many of the barriers that are outlined in the social determinants of health. So as a nonprofit society grounded in community, CHCs are positioned to be more responsive to local healthcare needs. So the next question is, how do we make it work? So how would we structure a community health center governance and operations in a way that facilitates the autonomy of the clinic operations, which many people are worried about, but also facilitates community engagement and support? So on the operations slide, which is what we're looking at, a clinical operations committee is comprised of all the practitioners and the office manager. So that is that group, and it will oversee the day-to-day operations of the clinic. So just an acronym, COC, we're just talking about the manager and the physicians. So it would, not the physicians, but the team members, all of the providers. So it would organize operations to ensure that the patients see the right person at the right time for the right problem. It would have input into the budget via the clinic manager. It would inform the clinic manager and the CPCC, which again, if you look up, you don't see it on the slide, but that would be more of the once removed folks. It would let them know what we need clinically. It would make decisions about key operational issues like hours, scheduling, coverage. And it determines the clinic needs and the priorities for digital health, like your EMR, et cetera, and how we can best utilize this for patient and panel management. That group would also be hiring team members, which is a big component of, I think, feeling like we have our autonomy and our independence. It would help determine what clinical competency were needed for team members and composition, and it would facilitate local quality improvement. measures. So on the other side, on the governance and community engagement side, a community primary care council, or CPCC, may the force be with you with the acronyms, but we need them. It links the CHC clinic to the local community, and it drives service design, accountability, strategic direction at the community level. It's comprised of the clinic manager, who's now in both groups, providers, both groups, community members, and patient representatives, and comes together less often, maybe quarterly. So this group would guide collaboration with appropriate nonprofits and community and private wellness services based on community needs. Just so you know, I think we've talked about this a little bit before, but the idea of having patients and private community members on a board can bring red flags to physicians, because we know there are a lot of things that don't work. And I think, okay, I'll speak for me. We fear that somehow they'll notice all these things and say, hey, please make this work. But when you have a local board, the idea is if things are found, that local board might be able to do the fundraising and figure out ways to make it work and actually take it off your plate. So, and with that, I digress. So this CPCC would also provide financial oversight at the local level, ensuring that the CHC funding is self-sustaining, approving the yearly budget, managing relationships with funders at a local level, and stewarding the long-term decisions about capital and large operational expenditures. That's fine. I didn't understand. There is one little comment in there, but that I'm going to drop off because it didn't make any sense to me. So what we're envisioning is a supported network of autonomous, self-managing community health centers across the Kootenay boundary area. So each one responding to the unique needs and priorities of its communities, while being linked and supported by a network of operational and administrative services. How this might work is the network support team would provide an infrastructure of financial, digital health, operation and learning supports across the network of community health centers. They would provide services like bookkeeping, physician billings, receivables, payroll, audit. They could oversee and make an operational budget for network support services. Might be owners or leasers, help with renovation, maintain real estate for each of the CHCs in the network. Again, this is a little vague only because it will be quite different for every community. The network support team would purchase bulk equipment and supplies, hopefully bringing down cost with economies of scale. It would develop and deliver infrastructure, support EMR integration across the CHC network, and IT, and use IT to help optimize learning. It would also support local human resources with templates, tools, guidance, just as needed, facilitating the sharing of expertise across the network, standardizing compensation, and setting some quality improvement indicators. Also continued support of professional development. So further towards the financial side of things, I think one of the hardest things is to get our head around, and we still have questions about how the financing for the CHCs might be structured. So the idea is once operational, each CHC would be 100% self-funding. So this includes its portion of cost for support network services. That means that the community health center in each community will need to have enough income to cover its overhead costs and all that applies, which we are very aware of, and its portion of the network support team cost. We expect several streams of income that can help pay for overhead costs. So physicians may be working on a fee-for-service or a salary basis. In either case, they would contribute an agreed percentage of gross income or a set amount to overhead costs for the CHC. Regarding the primary care network, most of you know who have been doing this, that there is, that the health authority does bring a set amount of dollars to help cover overhead costs. Another place of income might be rental income for community or private services to whom the CHC rents space. Grants are another option. As a nonprofit, the network will be able to apply for grant funding, not available to private clinics, and to support specific activities or outcomes. Community people can decide to support the CHC with direct contributions to running costs or via subsidies in different forms like tax exemptions, land grants, and local fundraising. So local community members via the CPCC may decide to raise funds locally to support the CHC. So how we get there? So divisions will provide legal and fiduciary oversight, establish a CHC support team, manage partnerships and negotiations with IH, the ministry, and regional partners and lenders, provide some efficient and equitable finance frameworks, and set up network support services. So that's, again, the financial aspect, the EMR, the IT. The funding for the network service incubation cost would be through the KB divisions or grant funding from CBT or others. Funding for capital costs like buildings and renovations. This will be based on the CHC direction. This may be, we may have monies from PCN renovation grants or community contributions. For those of you in the PCN process, there was some dollars for making those spaces better. Loans or equity funding from the CBT, credit unions, similar partners, extended amortizations and or interest or dividends just to support cash flow, possible some joint venture models, repayment and interest is to be covered by each individual CHC over time. So let me see. So initially, no, there was an added slide, I think. But anyway, so initially the KB division will provide incubation support for the first 3 or 4 CHCs and the network support team. And then we'll support the network to transition into being an independent nonprofit with its own governance board. So once operational, each CHC will be 100% self-funding, including its portion of costs for the support network services. The KB divisions will establish a CHC support team to support resourcing, planning, startup for each community health center. The KB divisions team will be coordinating directly with interested clinics to support the transition from private to not-for-profit community health centers. This includes managing partnerships and negotiations, again, with IH, ministry, regional partners, lenders, just to make this transition happen. It also involves setting up the operational, administrative, technological, and human resources needed to support by the network. It includes the operational and governance bodies at local levels, such as the budgetary and financial oversight processes at the network level. So through the incubation period, the division board will provide the legal fiduciary oversight for network activities. Funding for the startup costs of the network services will come from KB divisions and possibly grant funding from CBT or other donors. And I'm just going to look at something just to see where we are.
I think you've covered
I think so.
almost everything there, Ellen.
Yeah, I do too. Okay. So that is a bit of what we know so far, and the rest is up to sort of everyone to have questions and help us figure out what needs to be addressed.
So from here, thank you so much for Ellen for really just walking us through what the process has been and the vision itself. Now what we'd really like to do is get some clarifying questions. We just covered a lot. So Leah will be moving you into Zoom rooms, and we'd like you in each of your rooms to chat with the other folks in there and just generate clarifying questions. So you'll have 5 minutes. Hi, everyone. Welcome back to our main room. I hope everybody had a good chance to generate some questions. I think we'll start with group 1. And just remind our panel, you can put up your hands, Dr. Smart, Lori, I think we have Jan also, and Andrew. So group one, we'd love to hear from you. What's the question you'd like to put towards our panel?
Well, there were two main questions. One was regarding timelines. When did people have to sort of say they were interested in something like this? And the other big one was, how do you take a community that hasn't been forced to discuss this? I mean, there's been a push in Castlegar and a push in Trail from external factors to start talking now. But for Nelson, for example, they don't have this external force necessarily driving them. So how do you generate the conversation for that community?
Great questions. Why don't we start with number one, that timeline? Who would like to address that?
Why don't you take that one, Andrew? You've got the chart.
I'm avoiding that one because I'm busy writing my own questions and didn't hear exactly what Ellen said. But let me try really briefly and then tell me if I got it right, Ellen. Like, this is at a timeline that our community's clinics want. No one is, the division is here to be in a servant's position, I suppose, to a natural timeline that makes sense. And maybe if I elaborate on that, the division does not have a timeline or an agenda in this. When I say our communities, I think we have to acknowledge there are multiple players in those communities. From our perspective as a division, our prime focus is the timeline that our clinics are asking for. But that's complicated because in some communities, one clinic's in a real rush because it's incredibly vulnerable and others are not. So that involves dialogue between the medical staff of that community. In other communities, there are forces outside of the family medicine department that are also impacting upon this. We have the health authority building a new primary care space in Nelson right now. We have an NGO in that community that has been desiring to create a community health center for over a decade now, and is very keen on moving that forward. So it's a nuanced answer. But from the perspective of those on this panel, the answer is as fast or as slow as you want it to the extent that we have control over those time limits.
Okay, thanks, Andrew. Ellen, did you want to add to that? And then we'll move on to group two.
There might be some confusion because within our document, we talk about getting the first 3 or 4 up and running. And so I think it gives us a sense that maybe other communities who would like to do this need to wait. So I think we should explain perhaps where those 3 to 4 clinics running comes from. And Andrew, it's coming right back to you.
Yeah, sure. So I would say, middle April, I guess, a month into COVID, we started hearing from physician groups in both Trail and Castlegar saying, hey, we had those interesting engagements with you in January, February. I think we need to start this conversation in our community and we've got a bit of time on our hands. Let's start it. So there's 2 communities. Castlegar is a bit different in that actually well before the division even started these conversations, way back in early 2019, they engaged an architecture firm and they created a pretty picture that said, we have a vision for a new community-based health space. And they came to the physicians in Castlegar. And I don't know who came to the division first, whether it was the municipality or the physicians, and said, hey, we need to start having a conversation as a municipality and a physician community. Would you, the division, be part of that, sit at that table and help facilitate that? So those are the 3 communities where this has happened first. But absolutely, it's not only those 3. I think at the next MedStaff meeting in KLH, we'll be talking about things that are moving in Nelson. We have been in dialogue with the clinic on the East Shore, where there's a small community group there that would like to move this idea forward more rapidly. So yeah, this is it's moving in different places, different speeds and different locations. You're still on mute, Kate.
Thanks, Andrew. I want to make sure to give everybody a chance to ask their question. So I'm going to move ahead to group 2, and we'd like to hear from you about what question you had. If you have more questions, note them down, and if we can't answer them on this panel, we will follow up afterwards. So group 2, we'd like to hear from you.
I think the feedback that we got in the questions was fundamentally the funding model looks kind of sketchy, feeling like other CHCs have had a bucket of money from the ministry. And of course, this doesn't seem to be happening in this particular case. So it would just be a summary is it feels really uncertain how this actually would work financially. So it's a statement, but it's a question as well.
Okay, who would like to take that? I suspect that may go to you also, Andrew, unless one of the other of you would like to challenge to take on that challenge.
Well, I'll just comment that, yeah, I think in some models in the province, the ministry has dumped some money into some startup, but the CHCs as they exist and operate daily are, self, funding. And Ellen presented some options for funding and how we, can sustain that, but they do have to be sustainable from within. And now the big question is how do you do that? And do you do that in a fee-for-service model, in a completely salaried model? Well, most CHCs do run on completely salaried models. And we've been doing a lot of exploring around that, talking to a lot of other CHCs across the country and even in the US, and just to see how we can actually make it work. And that's probably one of the biggest barriers always is funding models. Funding models often, are in the way of how we want to do business. And it doesn't mean that we can't make it work. It just might mean that we have to be more creative. Andrew can probably speak more about how we have engaged someone in the community to help look at finances of several of the communities in the KB to actually see, what is that operational split and look like? Is that enough to sustain a CHC? Is there, is this the right thing to do for our community? Will there, we could, maybe there'll be cost savings, but I don't think that should be the reason to move ahead. I think my focus for me has always been on creating a more sustainable system in our community. And I mean, it's so funny because we think like we're not in crisis, but we're always just one or two providers away from being in crisis. And, building something that is sustainable and looking at some of the other areas where community health center buildings are still there 50, 60 years later. The only thing that changes is the people that work in them. That's probably enough. Probably
Thank
didn't
you,
even
Lori.
answer the question.
Thank you very much, Lori. I think the key points were there that there's a number of CHCs that are out there and they are self-funding. Did anybody want to add anything to that? If not, we will.
Could Andrew speak a little bit about some of the financial analysis that you've been doing, which gives you some baseline knowledge?
Yeah, for sure. I'll also add as a sort of a sidebar comment that, I've had some recent outreach with the BC Association of Community Health Centers, and they are optimistic that with the advent of the new government, there is going to be an unrolling of funding to do this kind of work in that model. But as you've noticed from our presentations today, we're proceeding as if that's not going to happen. I think my basic comment would be, this is not starting a normal business, right? You start a normal business, you don't know how many sales you're going to have, and you don't know what's going to cost you to deliver your service. We have very precise information available to us about the revenues associated with delivering primary care in our communities and the cost of doing it. And we not only have that information on a per community basis, so we can quite accurately model merging existing clinics and what their cost structure is, but we've now got, a pretty in-depth financial analysis at the division level of about 14 different medical clinics, and we know what the standard of operation is around the region. So simply put, we have a financial consultant that we've been working with for a couple of years now on this question. And the very first step in all of this work is to get him to put together a very detailed pro forma of what such an entity would look like. And if we see that pro forma doesn't cash flow out, doesn't tell us, A, we can afford it, B, it doesn't cost physicians anymore, then we wouldn't proceed. And so it's very, very much one of the very first sort of go, no-go decisions that has to be made is to actually make sure that the numbers are good. But like I said, it's not a normal business. That's not mystery. It's just work we have to get done early days and then move forward or not.
And then I would just add a comment from a community perspective, and I'm a person who has constantly been raising money for all sorts of initiatives in our community. It's often not difficult to get the capital dollars. You can go to the CBTs or the employers or whoever. It's what you can't get is the operating dollars, and so that's what has to be sustainable within the clinic. I think probably with KB Division's influence, there could be capital dollars secured for actual development of clinics where separate real estate is needed.
Okay, so there's a lot to talk about on this, and there may be more questions, and there's certainly more opportunity to provide feedback as we move ahead. But before we do that, I'd like to hear from group 3. What were your top questions?
So that was me. I can't even prioritize the questions, but I bundled them into 5. I'll just start with one that the other panelists could tackle. This is a lot of change for docs. It's overwhelming. We're doing just fine right now. How would this be supported and done in a way that minimizes stress?
Who would like to tackle that one?
I'll take a stab at it.
Okay, go ahead, Laurie.
Yeah, absolutely. Everyone on all levels is overwhelmed, and duly noted that this is a lot of change. And I feel like what we've been trying to do is work towards a solution that may not involve your constant attending at another 5 million meetings. And that was sort of the purpose of asking the board to become the incubator for the startup of this, and to actually, I think someone asked a question earlier about, you know, if I'm supposed to come to work and just enjoy work, but I still have to be involved in the clinical operations committee. Yes, you need a way to have input into how the clinic or center is running, but maybe you don't actually have to be the one that worries about whether the MOAs are getting their paid on time, and that someone has renewed the blah, 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 that we have actually people that are doing that work. And it does feel more like you're coming to a place to work and not to worry about how everything is operating on a daily basis. And in that, I mean, that's sort of, would be the nice way of coming to work, I would think, although lots of people enjoy the operations of systems, and that's great. And we're going to need those people, and we will be looking for those people, and they will have to take leadership roles as we move forward. But we don't really want to burden people. We know it's change, and change is hard. But I also would ask you to contemplate, if we do nothing, I still think we're going to be faced with a tremendous amount of work, and we may have change that is imposed upon us, and we're trying to take a more upfront, proactive approach to this. Ellen or Andrew, please, or Janet, please jump in.
I think that when we're doing okay, we forget about how, I think, Laurie, your comment of, it feels like often a community is like 2 physicians away of suddenly sort of failing. We know that recruiting is easier if you have kind of a network of people that are working in one place and you're not worried about business stuff. Being on the recruitment committee in Kootenay Boundary, I think it's pretty stunning how often people who are owning their clinics are struggling with trying to figure out splits, what's too high, what's too low, how do we recruit with this split? When we do that, then we've badly damaged our clinic and now we're unsustainable. But these things are kind of a constant. And it feels to me like when I first came here, it was a bit hard to recruit, but there wasn't quite so much in and out of physicians. And I just feel like we have been on that tight wire of figuring out how to keep the overhead going, how to recruit, and it changes so frequently. That I think people feel very vulnerable right now, a lot of the time. So that would be a piece that would be nice to get sorted.
Okay, thank you, Ellen and Lori. I want to make sure we have time to hear also questions from group 4 and group 5. So group 4.
Hey, Mona reporting here. I think you've dealt with some of the questions and there was some real interest in more details, especially around the financial process. So it seems to continue to be a hot topic. And, more of a comment than a question, but just wondering about, the capacity of providers to really take on this level of work and the capacity to drive this kind of change. And, suggestion that, really great clinic managers could be really helpful in the process to this forward, along with, I think Lori already kind of addressed it with us, the divisions team to provide that support. So some thoughts there, more so than questions. Then I guess the very first one was just, is this really within reach? Is this actually going to happen?
Yes.
Very good.
I don't have anything else really to add than what I said before. Maybe Andrew has more to add about, how, because we've had discussions amongst ourselves as a advisory group and at the board level, and we're also very cognizant of the extra pressures this puts on the people that work for us, like Mona and Andrew particularly, and Kate. So we're well aware that this is going to be maybe challenging, but we're also hopeful still. I think we still feel very hopeful.
I think what I would add to that, it kind of builds on what I was saying earlier around, this isn't a business that we don't understand. We understand this business pretty well collectively. And the nuances we're adding to it is different than what we're used to in Kootenay Boundary have been well documented by others, and they're more than happy to fill in gaps for us. So the main risk here is not the risk of the unknown so much as it's the risk of execution. And so as you think about, can we actually make this happen or not, then you have to put in checks and balances along the way that are clearly documented. They're basically milestones. As the group that's gathered to pull this off, have they accomplished this milestone in the time when they said they would, and did they do what we said they would? And if so, then we move forward and we go to the next milestone. And physician commitments to these things on a community-to-community basis scales with those milestones. And when I say the group that's doing this, I don't just mean the division and its staff team. I actually mean all of us, right? Can we, as the community of Castlegar, the medical staff in Castlegar, I'm just using one example, I can see 3 of you at once right now. What are the milestones that we have for our commitment to each other as a med staff to move deeper into this possibility? And are there places where we can turn around and go back because our execution competency hasn't landed properly in a good way? And we either need to revisit or go back to where we were before. So I think that's the challenge. It's a project management challenge. And that's not inconsequential, but it's nice to have only that problem, not also the problem of the unknown, like what our revenues would be and what our expenses would be.
And my sense is, we have clinics in Trail who really want to step in right now because there's some very immediate issues. So there's an opportunity for everybody to learn from the first guinea pig, right?
There's not any more burning questions right now, and certainly we're documenting all those questions. And if we have time at the end, we can take more questions. I would invite us to go back into small groups, and this time to really focus on feedback, right? And this feedback is really the purpose of that is to help us clarify and improve the vision that we've shared with you today. So please be honest on what you think would work, what you think wouldn't, and what you like to see added or taken out, or what you have kind of further input on.
And for clarity, Kate, we're each of our breakouts are starting with the group that the topic we had been talking about, and may move to other topics if we wish.
Yes, so we've asked you to start, each of you to start in different sections of the vision. So we've asked Dr. Smart to start in section 1, Jan, you to start in section 2. If you can give us some feedback on that section, and then add any other feedback or specific feedback on any other section based on what you would like to do and your priorities.
Kate?
Yes.
Can Can you clarify again, section 1? What is section 1, section 2?
I think Leah has just put into the chat
Okay.
the link to the Google Doc.
Okay.
So we've asked all of the scribes to go to sort of section B. You'll see there's a section for feedback, and it's kind of the boxes of the vision, the different little components of the vision, asking for your feedback on, I think number 1 is governance, Ellen. I think number 2 is finances.
Okay.
So just to kind of focus a little bit on that aspect, but then please, move on to the other pieces of it and share your input in those areas also. We don't want everybody to just talk about one section. We'd like to hear, make sure we get a little bit of feedback on all aspects. We want to just hear, do you feel this would work? How does it differ from your current practice, and kind of in negative or positive ways? And any other feedback that you would like to share with us.
Kate, I just wanted to say I'm not sure I stewarded my group's questions very well. So if there's time at the end, I would like to weave it in there, but let's go with this. Great.
Let's do the feedback, and then we'll hopefully we'll have time and we can have more time for questions. Hi, everyone. Welcome back to the main room. I hope you had some interesting discussions in your smaller groups. I think we'd like to start with perhaps group 4 this time and go in reverse order and hear from you one sort of your top key piece of feedback, either positive or negative, in terms of what you're thinking about the aspect of the vision that you were looking at. So group 4, I think that's you, Mona, your group.
Thank you, because I have another meeting to run to as well. We just kind of got into some real good discussions around the EMRs. While it might be a challenging aspect, they also felt that the technology is probably the easier piece to move forward amongst the community health centers. Really looking forward to the ability to view and share data on patients or patient information across the teams, but just really making sure that we do a good job of choosing the right type of technology, use some selection guidelines that are out there, and really be sure we're doing good training for everybody who's using the systems. The onboarding and learning of a new system can also always be a real bugbear for people. So there wasn't a lot of downsides to it, just really needs to be a careful, thoughtful process with really good support in terms of the training aspects. We spent a fair bit of time on the EMRs and not so much on the financial software and those pieces, but I think those are fairly standard in different clinics.
Yeah, the EMR is really the key piece.
Yeah.
Anything
James
else from group 4?
We're good.
Okay, thank you very much, group 4. That's great to get that feedback. So group 3, what were some of the top points that that you discussed?
Sure. So we were looking at the operational reality of what this would look like. And I think the summary comment that one person mentioned was that there's not really a big difference from the present. There's obviously going to be some devil in the details about who's who and who's doing what and how they relate to each other, but it's not radically different than what physicians experience now. We then moved into a more nuanced conversation, I guess, around, if you're looking at this for the first time, you really need a lot more information, both to enable your imagination to say, well, what will I be doing in this context, and how will it be different than I was before? What kinds of conversations do I have now, and which ones will I have in the future? Just to make it a little more real. And equally important, how is the financial reality different? And we ended the conversation with just an acknowledgement that there's a lot of chicken and egg associated with moving this forward. In a few months from now, we will be able to be sharing with other communities the detailed financial comparison between what's happening now in Trail and what's going to happen in Trail in the future, and how that impacts the individual clinicians on those sites. That's as I mentioned earlier, it's step number 1 in our decision-making milestone journey. But at the moment, we don't have that, and that is understandably kind of confusing and discombobulating. And when you overlay the unknown around what actually the revenue model is, given group contracts, fee-for-service, maybe community health center funding, that's also just a further level of uncertainty and confusion.
Okay, thanks very much, group 3. Group 2.
Okay, so I did jot down a whole bunch of notes, which we can kind of consolidate after when we're reflecting on the webinar. But I think if I can sort of catch in essence, on the one hand, there was that feeling that this is pretty overwhelming, and is there any kind of a way to do this step by step? But then on the other side, a really true recognition that team-based care is a really effective way for primary health to be delivered. And also that currently primary health is pretty underfunded, and that the fee-for-service model does not support team-based care. So feeling like there is a tremendous opportunity in this whole initiative to truly dig into what does team-based care look like. Nervousness about the funding base, nervousness about, I mean, let's stay away from grant funding for the day-to-day operations, because you're not going to get that deep, consistent model of care that there's lots of evidence that makes a real difference. So seeing the opportunity to genuinely shift to team-based care is exciting, but feels daunting and feels overwhelming at the same time. So my team, have I captured it, or is there something else you want to add? Jeanette, no more comments? Nope. Okay.
Okay, thanks very much, group 2. I'm back to group 1. I think that's you, Ellen.
Yeah, and our team, and I didn't get to hear much. Andrew was in there, but sorry, Andrew, you got cut off right at the end. So one of the feelings is, of course, the overwhelm, which is understandable. But I think another key piece was, how do we keep this from looking too much like a big conglomerate that is now saying, oh, you're out of budget, you don't get to do IUDs anymore. So how do you fund this thing, but also not leave too much of the control of how you do your office-based stuff from some person far away who makes these comments on what you can and cannot do and what your practice of medicine is going to look like. And so I think what our organizational structure and governance looks like, where does it get fuzzy and start to look like some of the big corporate entities on the coast are doing? On one hand, the people, big corporate folks, they have all this business sense, and they have all this, they have resources, lawyers, et cetera, that tell them how to do this. We don't, where are our resources coming from for financial support, et cetera? And how do we not get swallowed up like we might under a big corporate structure? That was a bad butchery, but Kate, you can fix that.
But it seems like it's really some key points just around being overwhelmed and needing to have some clarity on, again, that the key issue that I think everybody agrees is pretty central, the difference between kind of the operations, control of operations, operational autonomy, and the governance piece of it, which are pretty key. I think everybody agrees. I see that we're starting to lose some people, and we are down to about 6 minutes before we our planned end. Maybe I'll just open it up if there's kind of any last burning questions or comments. And if not, we'll move towards just wrapping up by looking at what the next steps are in this process and making sure we get you to fill out a poll before you sign off. So I will open the floor. Are there any last questions that you really feel like you want to put out there now, or kind of a last comment from anybody?
I'm curious what next steps are after this.
Okay, you're just taking us right to those next steps. Absolutely. Before I move to that and answering it, are there any other questions about the vision itself? Okay, why don't we just talk about next steps then? The next steps that we have, I hope I still have my screens up there. No. The next steps that we have are some further webinars like this one for practitioners and also for community members. So really workshops to hear more about what are the questions, what are the comments. And I think Leah is going to put into the, I guess we can put any further registration information we'll be sending out to everybody. So you can please encourage your colleagues to participate. We will be refining the vision and kind of the question and answers about it based on what we heard today. And then we're also working with the clinics that have expressed a lot of interest, the Castlegar Roslyn Trail, to help them kind of put in place a plan and move forward. And I don't know if any of our panel would like to have any final comments on kind of how you see those next steps moving forward, particularly in light of the issues that have come up today.
I think one of my driving points of curiosity is how do we really effectively engage community? And I'm excited to be able to see what that can look like. And I've been saying we have in the trail areas some people who are being patiently impatient. They want to become involved. So I think we can open up that question and see how community can support the process.
And Jan, I'll just add to that there's, I think, over 30 community members signed up for both the 9th and the 12th. So that interest is definitely there for them to hear more.
Okay, so we have a couple minutes left, and Leah, I think, has already put in a link for the poll. We would like to hear your feedback on the continued feedback on the vision itself, if you have more to add, and also your feedback on this webinar workshop itself. And with that, I think we can wrap up. If anybody would like to stick around, I know many of you have patients to go see. If anyone would like to stick around and has any further questions or comments, invite you to do so. A huge call out and thanks to our advisory group members, Lori, who's had to step away, Dr. Smart, who presented the vision for us today, and Jen Morton, who is constantly bringing that community's perspective and helping us keep our eye on the ball with that. So huge thanks to all three of you. And thanks to everybody for giving up your lunch hour and coming to help us make this vision bigger and engage on the topic, which is pretty important for our area.